We're live. What it feels like for us.
All right, we are live. Good morning. It's Friday, January 24th, and this is Senate Health and Welfare. We've had a really busy week, and it's not over yet. And we look forward to hearing testimony this morning from some folks, including Sarah Teachout. Sarah, why don't you come on up and share with us? Sure. Here you go. Do you know everyone around the table? Well, introduce yourself.
Senator Larry Hart, Orange County.
Sam Douglas Wallington.
You know the rest.
I do know the rest. Thank
Okay.
you. So I'll introduce myself. I am Sarah Teachout. I'm the Director of Government and Media Relations for Blue Cross and Blue Shield of Vermont. I have been with the company just over 7 years, I think. And prior to that, I spent over 16 years as staff here for the legislature in the Joint Fiscal Office. And I did all of the tax and revenue analysis. So it's a little bit of a shift.
Permanent seat.
Right. So I asked to come in, and I really appreciate Senator Lyons letting me come just to give you a quick overview of Blue Cross and Blue Shield of Vermont, and it certainly won't take long. And I don't think I can pull it up, but I'll just tell you that I emailed everyone this document. We're trying to provide a little more information.
Does Kiki have that?
I think she does.
It is on the webpage.
It's on.
I struggle a little with my computer and projecting, and our system's kind of locked down because we have personal health information, so I can't really access your system very often. So just to talk a little bit about Blue Cross and Blue Shield of Vermont within the Blue system, we are a little bit unique. I know a lot of people think we're one big national company, but we're actually 34 separate Blue plans, 33 of which are not-for-profit and one which is for-profit. So the one that is for-profit is Anthem Elevance. So, you know, we're all part of the same system. We work a little bit like a franchise where we each have territories that we're contained to work in. And there's a lot of rules about how we interact with each other. But the one thing that's most important, I think, for Vermonters is that we have a shared agreement across the entire system to create an in-network accessibility for all our members. So you can go to California and see an in-network physician or provider or anyone there, and they pay for it, and then we reimburse each other. So that's how that works with the system. But other than that, we're really independent and we operate individually. The one caveat there is that last year, Blue Cross and Blue Shield of Vermont became a subsidiary of Blue Cross and Blue Shield of Michigan. So they are also a not-for-profit single state Blue plan. We're a subsidiary, but we're really run separately. There have been some changes. The idea behind all of that was to give us access to economies of scale and a lot more efficiency and some technology that we really can't afford for a very small membership base. So we're the second smallest Blue plan in the country with 228,000 members. That's kind of tiny in the scheme of health insurance. Michigan has about 5.1 million members. So they have pretty good scale. So what we're trying to use is their technology and back office operations. We have about.
Sorry,
Yeah,
I know it's it's early for a question already, but I'm
happy.
I'm hearing, I think this might be the second time I've heard this presentation, and I am wondering, I know it's early, but is there any sense of the fact that now, you know, being part of the Michigan plan is going to be helpful, beneficial? Is any good news there?
Yeah, I think there is good news. And the places where we've really been able to achieve economies of scale are, for example, on the relationship with the pharmacy benefit manager. So they also use Optum Rx, but because they are so much larger and represent so many more members, they had better deals. So what we've done is merge the contracts, and we have, you know, one contract Another area that has been really helpful is NASCO, which is our claims operating system. Both Michigan and Vermont use the same one. Michigan actually owns NASCO. And so now we are able to use that system. You know, you have to pay to keep it up to date all the time. So now we have more economies of scale with that system. I would say that the places where it's more difficult is where Vermont's unique. You know, we're able to use their economies of scale, but then we still have to customize a lot of stuff for the state of Vermont. So
there's no risk pool.
no, yeah, actually very good.
Patients there, yeah.
We're completely separate organizations. So our reserves, our Vermont reserves staying here in Vermont, Michigan's just keeping everything separate. The premiums that are collected are kept separately. We're really run as completely separate organizations, financially. So,
Thank you.
yeah, great question. I'm happy to answer that. You know, there's more things that we hope to achieve for sure. And I think a lot of what we'd like to bring to Vermont is they have some really interesting technology that we haven't been able to access yet. So that's kind of the next goal, is to bring a lot of those things. Hopefully there'll be some more consumer facing improvements so that Vermonters will get to see it, whereas we see right now all the back office improvements. So we have about 400 employees, all up in Berlin on the Hill, all, you know, Vermont based here. I think the other information here was just about our membership. We've actually grown membership in recent years, so we're up to about 228,000. We certainly have the majority of the marketplace here in Vermont, but some of the reason for that is we're the only payer that offers health plans in every single market that Vermont has. So we do the Affordable Care Plan Act, we do large group fully insured, we have ASO or ERISA or self-funded plans, however you want to talk about it. And then we do the whole suite of commercial Medicare plans. So we do Med-Sup plans, Medicare Part D, Medicare Advantage. And then Blues plans across the country have the contract with the federal government for federal employees. So we also insure all the federal employees here in Vermont. So that's a little bit unique. And then the last little bit I'd like to talk about is the box that says operating responsibly. So just so you know, this is 2023 data, but we paid 1.5 billion in claims in 2023 for our members. About 25.5 million of what we pay out is for state and federal taxes and fees. And then it shows you here the percentage or the graph of our administrative expenses. So we're about 6.2%.
Yes, we heard that yesterday. It's pretty
Yeah.
amazing.
We're one of the lowest in the country. So that just means we're very efficient in the way that we provide our services. And we have been cutting administrative expenses recently to try and help shore up our finances. But if you look at that bar, you can see that even if we cut all our administrative expenses, it wouldn't do enough.
When you have claims listed, what does that include? Does that include the administration of the claims? No.
No, that's just
That's
medical
the money that's paid out to the
to providers.
provider. Okay.
Yeah, that's it. Administration is everything else. The costs of the IT system and the claims operating system, all the staff up at the office, our wellness programs for companies, utilization management, treasury. You know, we have a lot of divisions, provider contracting, just kind of all the stuff that it takes to make a plan work. So that was pretty much what I wanted to say. I think the last thing I would note, and we put it pretty clearly here, is that in 2023, for every dollar we collected in premiums, we paid out $1.11. That's not sustainable. So we really need to work to make that those things match.
Yes, no, we've heard, we understand that right now you're sort of on a precipice in terms of solvency. Can you talk about that a little bit?
I can talk about it a little, sure. Yeah. So let me just step back and talk about why health insurers have reserves. So I know this is basic for many of you, but we're required by the Department of Financial Regulation to hold capital reserves for all kinds of situations. And the most, really two things. One is, the annual ups and downs of health insurance. So what we do is we project how much it will cost to pay for our members' claims in the next year. We go to the Green Mountain Care Board. We actually have a bunch of processes, but the big one is the Affordable Care Act with the Green Mountain Care Board. We request a premium increase. They have their actuaries review what our actuaries did and update the work. It's actually a very collegial process, where I think they usually come to agreement about the sort of the approach to that. And then every year we ask, in a normal year, we ask for a 3% margin. It's called a contribution to reserves. And it's to put into our reserves. So the reserve levels have to, and there's a lot you could hear about reserves, and I won't go there, but the reserve levels have to minimally keep up with medical inflation. Medical inflation is more than 3%, even though we're asking for 3% every year. The idea is that we want to ask for a consistent contribution to reserves every year, and then make up the rest out of the investments for the reserves that we hold already. So usually that works. But what's been happening recently is, well, there's two things that have happened. So we're not perfect. None of the actuarial science is perfect. In a normal sort of course of business, we would be over a little bit some years, under a little bit some years, and the reserves would even that out. What's been happening in Vermont is that generally we have lost money every year, except for one, which is the year of COVID. So part of it is that the Green Mountain Care Board was not approving premiums that were adequate to meet our RIP funding. So that was happening for quite a long time. And then in recent years, they've worked really hard to give us the amount of premium we need to cover all the expenses. And then when hospitals specifically go way over their budget, and they're just like insurers, their budgeting works the same way. They're trying to target a budget, and in a normal course of events, they would be a little over, a little under, and a little over. They also hold reserves. But what's happened recently is they've gone way over in certain years. So that's money that no one budgeted for, and it comes out of our capital reserves. So that's been a big draw. Nationally, I think that what people are calling the surge in claims is happening across the country. So what's unique in Vermont is it's more extreme. We're just seeing a higher surge and more usage that's happening across the country.
And we have heard utilization is going up, but then in some hospitals in our state, the utilization isn't going up as much as others. So what are you hearing? I mean, both in state and then other states, do you have any of that information?
Yeah, I do. So utilization, so the reason costs are going up is complicated, and I don't think we all have exactly the answers. So we're looking at how many more patients are being seen. And we're seeing some increase, but it's about 5% more. It's not like tons and tons more patients. And I know we still have access problems, so Vermonters are still having difficulties getting in. What we're really seeing is that the costs are more and the prices are higher. And then the other thing is it's very hard for us to tease out what it is, but it could be that patients are sicker. It could be that there's more services being provided. What it takes to figure that out is a review of the medical record, and then, the claims, which is pretty complicated, and we can't do it on a broad scale. So it's probably some of all of those things happening. But we do know really that the prices in Vermont, when you look at them by any measure, for hospitals are some of the highest in the country.
What about pharmaceuticals?
Right. Pharmaceuticals certainly play into it and grow at a very fast rate. There's two avenues that you get drugs. One is the retail pharmaceuticals, which is what our pharmacy benefit managers do. And they grow at a pretty fast clip. What we're seeing is the underlying growth is pretty stable, but it's the really expensive drugs like GLP-1s for weight loss that are really outstripping the rest of the cost. So that's just one example. One everyone knows. There are some other kind of specialty drugs that are like that. Then there was drugs that you get when you're in the hospital, either inpatient or outpatient. So oncology, it tends to be the ones that are given to you as an infusion. Very, very high cost oncology drugs and some other things. That's actually, Vermont is ranking some of the highest in the country for the prices of those drugs. And that's in the RAND report.
That sounds inequitable. I'm sorry.
Yeah,
Yeah.
it's, and who it impacts most is not Blue Cross and Blue Shield of Vermont, it's patients.
It's, yeah, the patients are the ones that,
Yeah.
yeah.
So, did I fully answer your question? I'm not sure.
I do.
Okay.
No, this is helpful because, we hear things, we're hearing that Blue Cross and Blue Shield is having difficulty. You're our biggest insurer across the state, more lives than any other, and critical to our healthcare infrastructure. So what solutions are you looking at in terms of regaining solvency? And I know the reserve fund was a big discussion. You had to take some of that out. Maybe you could talk about how you use that to gain solvency and what are you looking at going forward?
Sure. So it's a multi-pronged approach. There's not going to be one answer. The one thing that we did immediately last summer is instead of asking for a 3% margin, we asked for 7% from the Green Mountain Care Board. They granted that. And so we know that it was one of the factors that made our prices go up by over 20% in the HCA marketplace. And that certainly could have some employers and individuals choose other plans, but for whomever chooses Blue Cross and Blue Shield of Vermont, they'll be getting significantly more because of that. So we're kind of, I haven't seen the latest enrollment figures from the end from the year, but I think enrollment is actually pretty good. I haven't heard about a huge number of losses.
It's good.
So that's one. What I was speaking about with Michigan is more of a long range plan. I mean, we knew that we needed to be more efficient a long time ago. So that's the longer range plan. We have also reduced our interest in the Vermont Blue Advantage Medicare Advantage plans. So that is one of the things that we've done. We have been cutting administrative expenses as an organization. That's only going to go so far. And we have borrowed money from Blue Cross and Blue Shield of Michigan. Again, that won't solve the problem, but it's, a temporary solution.
But you are encumbered. You will have to repay that.
Absolutely, with interest. So at the end of last year, our RBC level was 337%. We are supposed to be at 590%, according to between 590 and 670, I think, according to the Department of Financial Regulation. In our March filings, we will announce what they were at the end of December. It takes a while to roll it all out because we have 3 months of claims to roll out. So that will be an important indicator of how we're doing.
Cool. So, and now moving, any questions there? I know the economics.
That's super high level.
And finance really is responsible for digging deep into this, but we need to know this.
Yeah.
Any policy that influences what you're doing is important from here to there. So then we heard the other day from Dr. Soroyan about the blueprint. And I know that Blue Cross and Blue Shield has been involved in blueprint work. Can you talk a little bit about some of the clinical work that you're doing, primary care in particular, how that's sort of aligning with?
Sure, and I can bring in an expert too. And I have
it's just that you're
right. So, Blue Cross and Blue Shield of Vermont, like everyone here in Vermont, recognizes that primary care is the fundamentals of our healthcare system. And we want to do as much as we can to support our primary care providers. So we stopped participating in One Care Vermont 2 years ago, I think. But we took the money that we were using for primary care there and we reinvested it in our own program. So we have kept the same amount of money going towards primary care. Our program's called ECPC. I can't think of what it stands for right now. But essentially it's supposed to mirror the other programs that are going on. For primary care in Vermont, we give bonus payments to practices that achieve certain goals. What we've tried to do is make it so they don't have to submit any additional information to us. We're using all the same, information and data that they submit for Blueprint and you know the other programs that are out there. We've tried to make it really simple and continue that. We have another pilot program that we do with a few primary care practices in Vermont that's been more focused on certain chronic conditions. So I know it's really focused on diabetes and a couple of things that we've worked with them to provide kind of payments so that they can offer more services to their
It's
patients.
just like an all payer. You're doing.
The idea is similar, you know, they're supposed to be value-based payments so that the providers can do what they need. So for example, I know one of the things it pays for are those monitors, so people can look at their blood sugar levels. And what we're trying to do is before they're actually diabetic, you know, when you're pre-diabetic or facing, you know, some of the issues, try and get the information and the work with their primary care physician to them early so they can address these challenges early on, because waiting until someone needs insulin is not helpful. But I do have a one-page sheet on primary care that I can send you all.
That
So
would be
how would I
helpful.
do that? And then with Blueprint specifically, Blue Cross and Blue Shield of Vermont pays into Blueprint for our members, only the ones who are fully insured. So the Affordable Care Act marketplace people and also large group fully insured. I think we have maybe 2 or 3 self-funded plans that also voluntarily pay into that program. And we try and collaborate and work with the Blueprint so that we're all moving in the same direction with their programs and with our programs as well.
Okay, we can get into more detail going forward.
And I would want to bring one of our clinicians if you really
no,
want to talk about.
Because I know there are more detailed questions. There'll be questions that others have about other policies that are in place, so.
And another area I think I'd love to bring him in if you're ever interested. Our chief medical officer is Dr. Tom Weigel. He is I'm gonna get it wrong. He's very concerned about mental health, and that was his area of specialty before he came to us. So he has worked really, really hard to improve the access for mental health for Blue Cross and Blue Shield of Vermont members.
We'd like to have him in.
Yeah, it's a whole host of things like he's pretty much eliminated all prior authorizations around mental health, at least for in-state and network care. And he's also looked at expanding our network, both, with all the providers here in Vermont, but also remote providers and specialty services, sort of for more unique populations. So he feels quite passionately about it, and I think would be, really
Yes,
excellent.
definitely
About it.
Definitely. Good, thank you. Great,
Okay,
yeah.
thank you. I really appreciate the time. It's nice to introduce.
Well, it's just an intro,
Mhm.
and we want to make sure that we had you in here along with all the other folks who are coming in. And we're going to start moving forward to, obviously, we haven't talked about the AHEAD program in here yet, but we will get your take on where that is for Blue Cross and Blue Shield
Mhm.
as well. And then we have hospitals, we have hospital global budgets, we have electronic health records, and your organization is very much engaged, at least with Vital and with other areas. And we'll be looking at sort of how do we plan, what's the healthcare plan look like? So I think the committee will be trying to work together to put something on the table as a committee bill. We'll see how that goes, but it'd be important to have you here. Yes, ma'am.
I've got a question. Probably because I've been hanging out with Senator Brock for so many years. And he says we never ask Rennie, did it work? And a number of years ago, you had a thing where for the really high-end drugs, there were a limited number of pharmacies that you could get them in. We, in this committee, I will say actually negative vote, required that all pharmacies do that. The concern was that PBM, and my threat is I'm going to do an entire afternoon on pharmacy benefit managers if my committee is not good. I'm still catching flack for having Nolan in the health insurance thing on Friday afternoon.
I would.
That was rough.
But how has that worked out? Have we seen an increase in those drugs more than we would have expected?
Yeah, great question. The changes that you passed in the two PBM bills that went through the legislature 2 years apart are actually not fully implemented yet. So one of the changes you made in spread pricing hasn't gone into effect for our plan, but it will. So I would say that yes, we did see an increase in drug prices for our members. It's fairly complicated why it happened. But what we've seen is a loss of rebates for our members who are not getting drugs through the PBM, but they're getting them through hospitals. So we've seen a shift of where people are acquiring their drugs and we lose the rebate. And it's pretty complicated. And I know that you're going to get a bill about 340B. And when it comes in, I'd love to speak to you about what we're seeing in that space.
Yeah, we'll do that.
But yeah,
I know we're gonna get that, and we'll have you in for testimony on the bill.
thank you. I really appreciate it. But yes, there has been an increase in cost due to those changes.
For the newbies, it might be
Oh, what is
helpful
three
to
board for
have
you?
a primer, and some of us who haven't done it in a couple of years on pharmacy benefit managers and
We'll do that. Before, when we get to 340B, we probably should get into that a little bit. We can do that.
Yes.
Sebastian's watching. He did a really nice job.
Yeah, he's great.
that's right. I've been told that.
Remember?
Sebastian,
Yeah.
I know. I'm
He
not
did
heard
he
Sebastian
had
did
a
that.
chalkboard up there in our room,
Yeah.
and he drew a fabulous picture about PBMs and how they work. I actually have I have a,
No, I have him on the list. When I fulfill my threat, I ask Sebastian it to bill for finance because they are a major player.
Yeah,
yeah.
they are.
For better or for worse, it sounds like they're a mixed
Yeah.
bag. But they are a major player in the pricing of pharmaceuticals. And
When we did our gag rule legislation and it linked in with some other parts of the pharmacy benefit manager, I went to Florida and gave a talk for NASHB, and I still have the Kaiser flow chart for PBMs. So that I think would be fun to share. We'll do that. Very good.
if you can figure that out, you should go and get into gaming.
Yeah, it is.
Because you can-
It's like, it is. It's like a game. It's good.
Yeah.
So one of the things that Blue Cross has done, and I think other payers have as well, is we have a home drug infusion program. Because like I said, infusion medications are where some of the highest costs are. They tend to be chemotherapy drugs, but they can be others. And we know that patients would prefer to get their drugs infusion at home if possible, if it's medically appropriate. So it also saves considerable amount of money.
Was it here or in finance that we had a list of what things cost I think it was finance,
That's fine.
what they cost, yeah,
I have it.
in the hospital.
Yeah.
But the infusion was $6,000 in the hospital and $14 at home. I mean, basically they hook you up to an IV and you sit there for several hours.
Well, this is one of the transformation conversations that I think are going to be absolutely critical. And I'm not sure it's something we can resolve in here. We could, but having home care, moving things out of the hospital. That was one of Oliver Wyman's report recommendations, to move treatment out of the hospital when possible. And that's one of them that probably needs consideration here. Really amazing difference.
Yeah, there's a lot of benefits for everyone.
Right, oh, well, for the patient.
yeah.
Yeah,
Well, you can consider for chemo, if you live up in St. John's Ferry North, you have to go to Dartmouth.
yeah, it's a long.
And there's side effects that maybe you shouldn't be driving.
Yeah, somebody has to take off work to get you there.
Isn't there's even somebody to do that?
Well, the hospital in St. Johnsbury is Norris Cotton Center. That's owned by Dartmouth. That's off in St. Johnsbury. That's
I
something.
know they've been working out. I know Senator Starr was
My
really.
brother.
Thank you. I realize now that we're almost an hour early on the schedule.
I'm flexible.
And you showed up an hour early, so it's your.
Now you have more time for your conversation.
Yeah, well, I think, our committee will be considering some elements perhaps to put in a committee bill. We've been looking at EMR. We'll look at healthcare plan for the state. And we'll look at, principles to put in place perhaps for global budgeting or hospital budgeting. We have to look at that. How quickly can we get that alligator?
Global budgeting.
Global budgeting is where you have simplified forms, a set amount of increase over time based on mathematical formula paradigm. So we'll hear more about that. So right now, we know that we've got hospital costs like this and everybody's else all different like this. So what we need to do is to bring them closer. So,
Quickly, or we're going to lose hospital.
well, the questions, that's something that the Green Mountain Care Board then will have some responsibility for.
We almost
Without-
lost Bridget.
With maintaining some financial stability in our hospitals. And it's just catch-22.
Well, the hospitals also have a responsibility.
Well, of course.
Yeah.
Yeah, no question. Yeah, so we're gonna take a break. And then we're gonna go back